Good morning. I am Dr. Srikanth, Professor and HOD, Department of Pathology, Malareddy Institute of Medical Sciences. Today, I'll be discussing about leukemias, WBC disorders, and leukemias. So, leukemias, there is a lot of confusion between the students whenever we ask questions regarding the WBC disorders. The main question, whenever we ask the definition, it will be what is the definition of leukemia? So most of the students will be telling the definition as increase in the WBC count. So increase in the WBC count is called as leukocytosis. It's not leukemia. See, you all know the normal WBC count is around 4,000 to 10,000. So if the count is 15,000 means it is not uh, leukemia. It is leukocytosis. Sometimes in sepsis and acute inflammatory conditions, the count may go up to 40,000, 50,000 also. That means it is not leukemia. So leukemia definition is different. Leukocytosis definition is different. And one more entity is there. It is called as leukemia reaction. We'll discuss in the next classes. So, what is the definition of leukemia? Leukemia is, in common terms, we call it as blood cancer. But leukemia, you should know the exact definition as per medical terminology. It is nothing but the malignant transformation of blood forming cells. So, leukemia is defined as malignant transformation of blood forming cells. So, how leukemias are classified? So leukemias are classified into based on the number of blast cells. It is classified as acute leukemia, sorry, acute leukemia and chronic leukemia. So acute leukemia is classified based on the number of blast cells. So what are these blast cells? Blast cells are the first cell in all the series like myeloblast, lymphoblast, megakaryoblast. So based on the number of blast cells, the leukemias are divided into acute and chronic leukemias. Acute leukemias are divided into acute leukemias we can classify when the blast percentage is more than 20%. Whereas in chronic leukemias, the blast percentage is less than 20%. Okay. And based on the series of cell of origin, again, leukemias are divided into myeloid series and lymphoid series. Okay. Again, based on the lymphoid and myeloid series, leukemias are differently classified into AML and ALL, CML and CLL. That is acute myeloid leukemia, acute lymphoid leukemia, chronic myeloid leukemia, and chronic lymphoid leukemia. Okay. So coming to the definition, it is a malignant proliferation of blood forming cells, mainly the white blood cells. Okay. In the case of neutrophilic precursors, the primary process is marrow and peripheral blood, but can involve any organ or tissue which receives blood. So mainly the all the marrow blood elements are produced in the bone marrow. So the primary process is marrow and the peripheral blood, but can involve any organ or tissue which receives blood. That's why we call it as extramedullary hematopoiesis, where like hepatomegaly, splenomegaly, where there is involvement of other organs and tissues also. Okay. So coming to the today we'll discuss about acute leukemias, mainly the AML. In this class, we discuss about AML. So I told you it results from an abnormal clone of trilineage myeloid stem cells. Okay, the cells show some amount of differentiation, and more than one cell lineage may be involved. This is the basic common hematopoiesis. Okay, first the pluripotent cell, so it is again divided into myeloid progenitor cell and lymphoid progenitor cell. So again they are formed into the myeloid and lymphoid. They give rise to colony forming units. That is again the basophils, eosinophils, megakaryocytes, and again from there the mature blood cells. Okay. So this is the myelopoiesis. This will be very useful. If you know the myelopoiesis, then it is easy to classify the FAB classification and other acute leukemias classifications. Coming to the myelopoiesis, the first cell is the myeloblast, promyelocyte, myelocyte, metamyelocyte, band forms, and neutrophil. This is how the neutrophil is formed. So the myeloblast is I told you, the first cell Okay, and this is responsible for the malignant transformation. So there is mild difference between the myeloblast and promyelocytes. Even you see the nucleoli in promyelocytes also, but you won't see the granules in myeloblast. The granules you see in promyelocytes, okay, and compared to myeloblast, the promyelocyte size is some little bit larger. Okay, so we will discuss about what are the differences between the myeloblast and lymphoblast. But this is the common myelopoiesis. Okay, myeloblast to neutrophil. See, this is the difference. I told you the first cell in all the series is the blast cell. Okay, so this is the difference between the lymphoblast versus myeloblast. This is very important. So lymphoblast, coming to the nucleoli, the lymphoblast will have 1 to 2 prominent nucleoli, whereas myeloblast will have 3 to 5 nucleoli. Nuclear chromatin it is coarse in lymphoblast, whereas in myeloblast it is fine. NC ratio is high in both lymphoblast and myeloblast. OR rods, what are these OR rods? OR rods are the acidophilic granules you see in the cytoplasm of the myeloblast only. All rods are seen only in the myeloblast. All rods are not seen in the lymphoblast. If you are seeing all rods, it's clear cut. It is indicating it is myeloblast and it is of myeloid origin. Okay. All rods are seen in myeloblast and they are absent in lymphoblast. So accompanying cells we discussed, lymphoblast you see mainly the lymphocytes, whereas you see promyelocytes, myelocytes and all. MPO stain, the myeloperoxidase stain, as the name itself indicates, myeloblast and myeloperoxidase. So MPO stain is positive only in myeloblast, whereas MPO stain is negative in lymphoblast. And other stain, Sudan block B, it is positive in myeloblast, whereas negative in lymphoblast. FAST stain, that is periodic acid shift, it is negative in myeloblast, whereas it shows block positivity in lymphoblast. These are the differences between myeloblast and lymphoblast. Okay. So there are two classifications. One is WHO classification of AML and another is FAB classification, that is French, American, British classification. So WHO World Health Organization classification of AML, it is the classification incorporates based on the morphology, clinical features, cytogenetics, and molecular genetics. So the classification incorporates mainly the morphology, clinical features, and cytogenetic and molecular genetics. So coming to the diagnosis, the cutoff blast cells in marrow for AML is 20%. I told you already. So this is the proposed WHO classification of AML. So first one, actually, the latest again the classification is changed, but this is the as per the Robbins the classification is there. So AML with recurrent chromosomal rearrangements, that is, it includes the AML with translocation of T821 inversion 16, T1517. So next is AML with multilineage dysplasia, if that is with prior myelodysplastic syndrome or without prior myelodysplastic syndromes. Next is the AML therapy related, the drugs like alkylating agent related or epiphodophyllotoxin related. Okay. And next is the AML not otherwise specified. Okay. It includes the subclasses defined by extent of differentiation and FAB classification, that is M0 to M7. So WHO classification, it is based, first one is a AML with recurrent chromosomal rearrangements. Okay. Next is AML with multilineage dysplasia. Third is AML with therapy related and AML not otherwise specified. So here the second entity, that is AML with multilineage dysplasia and AML therapy related, they have very poor prognosis. So coming to the FAB classification, this classification, it includes from M0 to M7. So routinely when we are reporting, we fit into one of the FAB classification like AML, M2 or M3. So M0 to M7. So M0 is AML with minimal differentiation. M1 is AML without maturation. M2 is AML with maturation. M3 is acute promyelocytic leukemia. M4 is acute myelomonocytic leukemia. M5 is acute monocytic leukemia. M6 is erythroleukemia. And M7 is megakaryocytic leukemia. So M0 to M7. So AML with minimal differentiation without maturation. With maturation, AML, promyelocytic leukemia. And again, it is divided based on the number of granules. It is hypogranular, hypergranular, myelomonocytic, monocytic, erythroleukemia, and megakaryocytic leukemia. See the same, the revised FAB classification of AML, that is from M0 to M7. So based on the incidence of number of percentage of AML and marrow morphology. So in AML, see, first thing, age group, if we take ALL, especially some variants are the subtypes of ALL, they may seen in middle-aged persons also. But ALL most commonly it is seen in children. ALL is most commonly seen in children, whereas AML is seen in middle-aged groups, okay, and CML they're seen again in the middle-aged 40 to 50 years, and CLL, that is chronic lymphocytic leukemia, you see in the elderly age groups around 60 to 65 years. So coming to the AML, it is common in 15 to 39 years with male preponderance, that is middle-aged. Patients present with anemia, bleeding tendencies, infections, okay, organomegaly, it can be hepatomegaly or splenomegaly, bone tenderness, okay, skin infiltration as nodules. Again, this is separate. We'll discuss chloromas, mainly seen M4 and M5. It is, you see skin infiltration as nodules and gum hypertrophy and gum bleeding will be there. So how the patient will present? Definitely the patient will present with weakness, lethargy and all. And there are bleeding tendency in the gum hypertrophy and bleedings from the gum. If the patient is presenting with these symptoms, then we can suspect AML. Okay, fever, CNS involvement is there, but it is not as a ALL like cranial palsy is fifth to eighth, and granulocytic sarcoma is nothing but the chloroma we'll discuss. And one more entity for ALL, the child will present with CNS involvement. The child can have symptoms like meningitis, and he also presents with there is involvement of testis also. Testicular involvement is also there. See, this is photograph of the gum hypertrophy. You can see, we see in AML M4 or M5. See the entire thickness of there is hypertrophy of the gums seen in AML M4, same gum hypertrophy in AML M4. You can see the entire replacement, same thing. So coming to the microscope, with the peripheral smear, what you see under the microscope, the basic investigations we go for with the peripheral is complete blood picture, that is the acute for AML. You see all the cells what you are seeing are the myeloblast. They are all the myeloblast. You can see they are very large. If you see, you can see 2 to 3 prominent nucleoli. Okay. This complete, you can see background, you can see RBCs, but these are all the large cells around 16 to 18 microns with 2 to 3 prominent nucleoli with scant, with moderate amount of cytoplasm. They are all the myeloblasts. This is a case of M0. So this is a case of M1. Okay. These are all the myeloblasts with the prominent nucleoli and moderate amount of cytoplasm. Blast cells. Same AML M2. You can see the entire slide up to 60 to 80% of myeloblasts. See here in this slide, you can see here the 3 o'clock position. You can see one needle-like uh, thing in the cytoplasm of the myeloblast. That is the OR rod, the needle-like azurophilic granule positive, which you are seeing in myeloblast, in the cytoplasm of the myeloblast. It is called as OR rod. The same, you can see plenty of myeloblasts. So again, in the center of the myeloblast, in the center of the cells, they are all the myeloblasts with prominent nucleoli. You can see one odd rod, the needle-like thing. Here also you can see the odd rod. This is positive stain showing positivity for myeloperoxidase. Myeloperoxidase positive. Okay, you can see the myeloblasts are stained positive with MPO stain. So here in the center, these are all AML M3, that is promyelocytic leukemia. If you're seeing a single needle-like thing, it is called as odd rod. But when you're seeing a bunch of odd rods, it is called as fagot. See AML M3, these are all the tumor cells, um, buttock cells. So here in the center, when you can see plenty of odd rods, it is called as fagots. This is a fagot odd rods. Same AML M3, M4. You can see all the myeloblasts here. M5, monocytic, erythroleukemia, M7. So mainly the you can see up to 60 to 70%. Actually, to call it as diagnosis, it is AML. There should be more than 20% of the blast cells. That is a myeloblast. So in conditions like M2, M1, you can see up to 80% of the or 90% of the cells are replaced by the blasts only. And you can see occasional odd rods. So this is the cytochemistry of AML. That is M1 to M7. Percentage of cases, the M3 is only 5%. The cytochemistry, I told you, we already discussed the myeloperoxidase, Sudan black, they are positive and all. But M4 and M5, you can see non-specific NSC is also positive. And M6, it shows block positivity for periodic acid shift. So what are the clinical features of AML? So the patient presents with anemia, weakness, ecchymosis, fever, fatigue, and mucosal hemorrhages like the effect of the gum hypertrophy. Why there are more bleeding gums and bleeding tendencies? Sometimes the patient may present with epistaxis because mainly the main reason is the procoagulants and the fibrinolytic factors released by the leukemic cells. The procoagulants and fibrinolytic factors released by the leukemic cells, especially in acute promyelocytic leukemia, they exacerbate the bleeding diathesis. Okay, infections are common in the oral cavity, skin, kidney, urinary bladder. Mild organomegaly can be seen. CNS spread is less common in ALL, okay, but ALL, CNS common is more in ALL only. So these tumors, other entity we'll discuss like chloromas or granulocytic sarcomas. In- So lab diagnosis of AML, the WBC count is more, leukocytosis you will see up to 1 lakh. HB is normocytic or macro. Peripheral smear, you will see more than 20%, up to 96% it can go, the blast cells, okay. If you see bone marrow aspiration, it will be hypercellular and it is replaced by the leukemic cells and there is suppression of the normal marrow elements. So coming to the ALL and AML. So ALL, um, mainly you see in children, whereas ALL, AML, you see in adults. Lymphadenopathy usually present but absent in AML. CNS involvement is more in ALL and sometimes very less in AML. So testicular involvement is more in ALL. And prognosis, coming to the prognosis, ALL has good prognosis compared to AML. Thank you. Thank you.